Let's talk about the failing heart, shall we?
Okay.
Heart failure.
Yeah.
You ready for this?
It's so sad, the heart failure.
You ready?
Yeah.
I like your emoticon. It's very
Yeah.
next level.
Yeah.
Oh, you like that?
Yeah.
Thank you.
It's cute.
It's so 2002.
Heart failure is the inability of the heart to maintain sufficient perfusion for normal function. Now, we're going to go over this a number of different ways because heart failure can be divided into 50 different types, whether it's systolic or diastolic, and whether it's forward and back, and whether it's left side, right side. So it gets very confusing. So I'm actually going to go over this section a few different times. In reality, mostly what you care about is whether it's systolic failure or diastolic failure, whether it's right or whether it's left.
Check.
Systolic failure is simple. Here we go.
Okay.
Bring me a little steady cam action. Because I've been working on this for a while.
Oh, really?
You ready?
Yeah.
This is your heart, Paul.
Yeah.
Systolic failure, well, here's a normal heart. Ooh, ooh, ooh. See that?
It
Good
makes
contraction.
a funny noise, but oh yeah, good.
Ooh, ooh.
It's like an owl heart.
Systolic failure is
Paul's heart's invisible.
Yeah.
eh.
Yeah, I like
Systolic failure, failure to contract. If you can't contract properly, you're not going to perfuse, you're going to get short of breath.
Yeah.
Diastolic failure is contract well. Ooh, really slow filling. Ooh, really difficult to fill. That's diastolic failure. Do you like that?
I like
Ooh,
that.
really slow filling. Thank you, Paul. You're a good man. I don't care what they say. So then you divide it into left-sided or right-sided. Left-sided failure is your left ventricle can't contract. And so then when you go walking up the stairs, you can't perfuse your muscles, so you get fatigue. You can't perfuse your kidneys, so you get renal dysfunction. And the blood starts to back up into the right side, so you get short of breath in your lungs. That's classic left-sided failure. Classic right-sided failure is the right side's not pumping, so the fluid backs up into the periphery and you have edema. You have jugular venous distension. And this is confusing because the commonest cause of right-sided failure, Aaron, is what?
Left-sided failure.
Thank you. So your left side fails, it backs up into the lungs, and then your right side fails. So these two often go together. You can, of course, have pure right-sided failure.
Do you ever think of diastolic failure as you think of it as an enlarged heart too? So it's not necessarily stiff, you can't open. It's also like big.
Well, no,
wide,
diastolic
right?
failure can be just a heart that just is normal size and doesn't fill.
Yeah.
Or it can be, you can have diastolic failure with
Dilated.
big failing ones.
Like a dilated cardiomyopathy is a
It's a systolic problem usually.
systolic problem.
Yeah. So it's mostly filling, because it turns out that filling is an active ATP process.
Right. So
And then
we're
there's
mostly seeing
restrictive
systolic.
cardiomyopathies, which we'll talk about, where the wall itself is so stiff, but that's a form of diastolic failure as well.
Cool.
All right, let's take a quick crack at the Frank-Starling curve. So this is stroke volume over here. This is left ventricular and diastolic volume over here. You'll see generally three things kind of like this. Actually, I don't like that one. Let's do this again. Let's do this. So you have curves that kind of look like this. And what does this mean? So this is your normal. And what this says is as you fill up your heart, you've got increasing end diastolic volume. At the end of diastole, your heart is fuller and fuller. You get more and more stroke volume. So you pump out more. If I add catechols to the mix, which is this line, I get an improved ejection fraction. I really squeeze out at the same same sort of volume of end diastolic volume. I can actually get out more if I give you catechols. And this puppy down here is the failing heart. So in the failing heart, in systolic failure, at any level of end diastolic volume, any filling of the heart, it doesn't squeeze out as much as a normal heart, so it can't get as much out. And then when it passes this point of maximal stretch, this is the point at which you get the most amount of stroke volume for the amount of volume in the end of your heart. So you stretch it up to the point where it's maximal. This quickly fails. So a lot of people in heart failure will stretch up their heart. I need more stroke volume, I need more stroke volume. But they reach this point where they get much worsening stroke volume. A lot of the therapies we have in CHF is to move them back, to actually shrink down the heart a little bit with things like nitro and BiPAP by reducing the amount of blood coming to the heart and therefore lowering this end diastolic volume and moving them back on this curve to the maximal area they can get the most cardiac output. It's quick, it's dirty. I don't know how they'd ask questions on it, but everybody talks about it. All right, Paul, quickly, he's on the Steadicam. First of all, find out what that truck noise is. Go. And then we have something else important for you to do. I hope you enjoyed that.
We hear that a lot. I've
Frank
always
Stone.
wondered what was happening out there.
What's going on out there?
Oh. We're going to need to get that guy to sign a release now.
What the hell is going on out there? Boys, talk to me. Just a
Well,
giant
neither
truck.
one of them have mics on.
Oh, that's a problem. Actually, and here's another thing I'd like you to do, Paul. See that skeleton over there standing next to Aaron? I wonder if you could just lift up the dress and see if it's a boy or a girl. I've always wanted to know. Let's
Don't
see.
do that, Paul.
Do it.
Don't
Let's
do
see.
that.
Lift it up.
No.
Lift it up. Let's see. Oh, you are such a flirt. All right. Let's get back to the educating here, shall we?
Let's do it.
As a speaker, it's always exciting when you're paused over your clicker, having no idea what's coming next. This is one of those times, ladies and gentlemen.
Yeah.
Oh, causes of heart failure. Here we go. So, systolic, failure of able to contract. What are the commonest causes of this? Hypertension and ischemia are by far the most common causes in the Western world. All right, so if you have an infarct and you take out half your heart, or you slowly have ischemia over time, you can't contract. Valve disease is another important one. Non-ischemic cardiomyopathies, you get some bad virus that takes out your heart. The list is huge. In Harrison's, the list goes for pages. But the big ones, hypertension and ischemia. In fact, over the age of 65, it's mostly, by far, ischemia in most studies.
I concur.
Thank you, Skelly. Skeleton. Silly skeleton. Tell me about high output failure, skeleton.
Well, in high output failure, I
Yes.
lost the slide. High output failure.
Oh, you need the slide skeleton. Oh, I see.
You don't have
Let
it
me
on the
tell
other
you,
screen?
I do actually. Yeah.
high output failure occurs when you have, over time, your heart is working really hard, like this. I have thyrotoxicosis. I have chronic anemia. I have a baby. I have Paget's disease, and I'm doing this all the time. You know what? You shouldn't eat M&Ms when you lecture.
No, you shouldn't.
They get caught in there. But if over time, high output failure, you actually get a remodeling of your ventricle so that it can go into the systolic failure state. It's not good for you to be going fast for a long time.
No.
So
Remodeling. Do you need permits for that?
remodeling, not
Yeah.
Brazilian modeling. Diastolic failure. Again, remember we said this is you can contract well, but you take a long time to fill up. You contract well, long time to fill up. The single biggest cause in the Western world of diastolic dysfunction, which is about 30% of all heart failure cases, is hypertension. Your heart, which is pushing against this really big pressure, gets thicker and thicker and thicker, and that muscle is not very distensible, so you can have signs of heart failure, even though when they echo you, your ejection fraction's 75%. It's because it's not filling, and if you can't fill, you can't eject, as it were. Aortic stenosis for the same reason. Scarring after an MI, if you have a big MI and it won't move, diastolic failure. Diabetes, glycosylation of the heart, it starts to get all stiff. Ischemia, so acute diastolic dysfunction occur when I give you ischemia, Aaron,
Yes.
and your heart's like, I got no energy, I can't fill because it's an energy requiring process. But the end point of even diastolic failure over time is actually systolic failure. So you can imagine the person who's got long-term hypertension, first they get a big, strong heart that doesn't fill, but then as it fails, it stretches out and gets weaker and weaker and develops systolic failure. Here's a classic chest x-ray of what you might find on exams of somebody with CHF. So let's go through some of these things. You have a big heart. You have upper lobe diversion, which is basically the same as jugular venous distension. You've got all this upper lobe diversion. You've got these curly B lines, which are short, fat, horizontal lines in the periphery with interstitial fluid. And you get your loss of costophrenic angles because you've got pleural effusions. You've seen this 100 times in clinical practice, and they'll have a really poorly produced one like this on the exam for you as well. Tom's telling me to drink. Excuse me.
How many M&Ms did you eat?
I ate all the M&M.
It's like every time the camera goes off you have an M&M problem.
Well, you know, I need my uppers.
M&M.
How do we treat these people? IVO2 monitor, advanced air equipment at the bedside. We reduce preload. The reason we reduce preload is because of that Frank-Starling curve. If I can shrink the size of your heart by, reducing end diastolic volume, then I get your heart back onto the part of the curve where it can contract better. Some people also use a little bit of morphine. Sometimes we use some nitrates if they've got lots of edema, but you've got to be careful with the nitrates because you can make their renal function worse. BiPAP and CPAP. How do BiPAP and CPAP work? They work by reducing your work of breathing, because BiPAP, for example, you take a breath in and it shoves air in, so I can have a bit of a rest of my diaphragms. But also it increases your interthoracic pressure, therefore decreasing your venous return, therefore shrinking your heart, therefore moving it to a better part on the curve for you to contract.
Therefore, there's
Therefore,
nothing else.
There's nothing
There's a
else.
lot of therefores.
A lot of therefores. Afterload reduction, nitroprusside. ACE inhibitors, high-dose nitrates, that can also be useful so that your heart doesn't have as much pressure to push against. If you're really, really sick, you get inotropes, although they've never been shown to work. But if you're sick and dying, cardiogenic shock, we'll use inotropes. And remember this, and this is more the internal medicine thing, but we all know this. If you've got chronic heart failure, Tom, it is worse than most cancers. The mortality at 5 years is like 60 to 70%. Once you've got chronic heart failure, bad. It's not a very reversible disease. Here's a quick Trivial Pursuits question. Who said this? Nothing succeeds like, can you finish it? Excess. That's right, ladies and gentlemen. Oscar Wilde said this. And he said, moderation is a failure. Nothing succeeds like excess. That's why we're going to do another summary right now. Aaron's looking at him like, what the hell is this slide here? I'll tell you what this slide's here.
Could you?
I'm going to go over this heart failure thing again because it really confuses people.
Yeah.
So, cardiac failure, again, let's go over this. It's the inability of the heart to pump enough blood to meet the body's needs. You can have high output failure or low output failure. High output failure, for example, thyrotoxicosis. Low output failure, I just have systolic failure and I can't pump. We have systolic and diastolic. Systolic, I can't contract very well. Diastolic, I can't fill very well. Classic example, hypertension with a big, thick ventricle. Right-sided heart failure, mostly edema in the periphery. Left-sided heart failure, I can't walk. I get really weak, and that backs up into my lungs and I get short of breath. You can have acute versus chronic. I can give you heart failure right now by giving you an MI.
Don't.
Or I can give it to you over long term by giving you a high blood pressure for years and years.
Okay.
Nope,
Hey, wait.
I won't have that either.
In between that slide, so which is the big, thick you said hypertension causes which? Systolic versus diastolic?
Diastolic.
Okay, good. Then you said it right.
Systolic failure. Remember that ischemic heart disease and hypertension are the commonest causes for this. The symptoms are weakness, fatigue, shortness of breath. S3, often on exams, a third heart sound and a PMI that's displaced, a big heart that's moving over here. Right-sided symptoms, yes, you can have shortness of breath and cough, but classically it's the peripheral edema, the jugular venous distension, and the hepatic congestion, all right? And edema that's in the sacrum and in the legs. How do we work these people up?
How do we work them up?
Well,
Let's chat
you
about it.
get a history.
Yep.
You do an EKG, which is non-specific. It usually just shows a big left ventricle. Arrhythmias, which can be sort of all over the place, but classically as you dilate up your heart, you get a lot of atrial fibrillation.
Check.
Echo is the key thing, right? That tells you whether they're filling. It tells you how much they're contracting, all right? So ejection fraction, wall motion, all this stuff. It's also useful to tell you if there's a big clot in there you need to do something about. And transesophageal is certainly better in lots of cases than transthoracic, but transthoracic is all you need in most cases. So echo is the key diagnostic workup. Now, are the board's going to ask you about BNP levels and all this stuff? That was trendy a while ago. Now it's mostly gone away. Really what you need is an echo to make this diagnosis. How do we treat these people? We talked about it. IV O2 monitor, nitrates to unload them, reduce their preload, IV ACE inhibitors, diuretics, and aceratide is out.
Yep.
It's out now on the boards and in life. It hurts you more than helps you. Press is only for the sickest patients because they really don't help. There's a particular form of heart failure that's one of my favorites.
It's in lights right there.
It's called cor pulmonale,
Uh-huh.
and that's right-sided heart failure. What's
Yeah.
the commonest cause of right-sided heart failure?
I would say left-sided heart failure.
Thank you.
Ooh.
Left-sided heart failure.
Who
But
has
you
a-
can get pure right-sided heart failure. Yes, Tom, you have a question?
Who has a favorite heart failure?
Oh,
What
I
kind
do.
of guy has a favorite
Mel
heart
Herbert.
failure?
That's my
Mostly Australians.
favorite.
Land of criminals. You know this place.
My favorite. So if you've got pure, mostly pulmonary disease, COPD, pulmonary fibrosis, pulmonary hypertension from vasculitis, your lungs are all bad, and the intrapulmonary pressures are really high. So your right side of the heart has to press against this increased pressure, and over time it fails. That's when you get pure cor pulmonale. The diagnosis
Stupid
is
heart.
stupid heart, right ventricular strain, classically T-wave inversion V1 through V3. That's classically with acute cor pulmonale. We'll talk about in a second. Right bundle branch blocks, S1, Q3, T3s. Chest X-ray usually doesn't show too much. Echo is the key diagnostic process again.
Mm-hmm.
So here is another important concept. Come on, bring it in, Paul, bring it in. This is very important. I want you to focus on this. I want you to be with me on this one, okay? We just talked about cor pulmonale, right-sided heart failure. What is the commonest cause? Sorry. What's the commonest cause of acute right-sided heart failure? That's right, ladies and gentlemen, boys and girls. PE. If you have a huge PE, all this clot goes in your lung, and your right heart goes, I can't contract against the stupid pressure because there's a giant amount of clot in there. Produces acute right strain on EKG, which is right axis deviation, right bundle branch block, T-wave inversion V1 through V3, and then the classic S1 Q3 T3, which is useless, but it's on the exams.
Yep. It might be there like as a secondary thing, eh?
But actually much more important is this V1 through V3 T-wave inversion and right bundle branch block. So here's
a
an
sort of
example.
generic normal looking EKG. Some of the manifestations, just some of the manifestations of PE on an EKG. You might have a sinus tachycardia, okay. One that I like is this T-wave inversion in the anterior leads. T-wave inversion, here it is in red, in the anterior leads here. That's a sign of right ventricular strain, as you might expect, a RSR. So a right bundle pressure, RSR prime. So right bundle branch block, T-wave inversion, anterior leads, V1 to V3. You might have that classic S1, which suggests right axis deviation. Q in 3, T-wave inversion in 3. These are just some of them, all right? So evidence of right ventricular strain and this classic S1 Q3 T3 you'd need to know for the exams.